Welcome back to the deep dive. Today, we're tackling something really critical. It's an area where, well, quick thinking and spotting the signs can genuinely save someone's sight.
Absolutely. We're talking about non-traumatic ophthalmic emergencies.
Right. These aren't from injuries. They just happen.
Exactly. Sudden onset, sometimes even painless, but they demand immediate attention.
And to really get into the weeds on this,
Yeah.
we're using Parson's Diseases of the Eye. Specifically, Chapter 29 is our guide. The goal here really mirrors the source's aim, equipping you, as a first contact medical professional, with that foundational knowledge.
Enough to spot these things, understand the urgency, start thinking diagnostically, and know those absolute first steps before, the ophthalmologist gets involved.
We want to help you build that internal radar, so when you see certain symptoms, alarm bells start ringing. It's about really understanding the nuances.
Precisely. Mastering the subtleties hidden in the presentation. So let's unpack this.
Okay, so the material kicks off with a core principle: speed. Fast thinking, quick action, absolutely essential here.
Couldn't be more critical. And the pathway the source lays out is, well, it's quite clear. First, recognition. You have to see the potential emergency.
Recognize it and understand the urgency.
Right. Then you need a rapid diagnosis, or at least a strong suspicion, and accurately estimate how serious it is, the gravity.
And finally, take prompt, appropriate action.
Exactly. And it stresses, this isn't just about trauma cases. These non-traumatic situations are just as demanding, speed-wise.
And it's vital for all medical professionals to have this basic knowledge. You might be the first person they see.
Your initial actions can profoundly impact the outcome.
Absolutely. Okay, so to help structure this, the source breaks these emergencies down. 4 basic categories based on how they present.
Yeah, it's a really useful framework. First, the painful red eye.
Okay.
Second, the painless red eye, though. Honestly, the source focuses more on the painful red eye and vision loss categories.
Got it.
Third, acute painful loss of vision.
And fourth,
Acute painless loss of vision.
that really helps narrow things down from the start. And the stakes are incredibly high, as the source points out.
Immense. Accurate diagnosis, timely management, that's the absolute key to preventing permanent vision loss, preventing disability.
So how do we get there? The systematic examination seems crucial.
Paramount. The source details the steps. You absolutely need to check visual acuity, central vision,
Right.
visual fields, even just by confrontation. Pupil size and reaction, that swinging flashlight test, is non-negotiable.
For the RAPD, right? Relative afferent pupillary defect.
Exactly. Tells you about optic nerve function, then extraocular movements, a good look at the anterior segment.
Ideally with a slit lamp, but magnification helps regardless.
Yes. And the posterior segment funduscopy. And always think about associated systemic diseases. You have to ask.
Okay, let's focus on that first category then. The acute painful red eye. The source gives us 5 key conditions to consider immediately.
Right. Your differential diagnosis for that painful, non-traumatic red eye should include 1, conjunctivitis,
The common one.
2, a foreign body on the ocular surface,
Okay.
3, corneal ulcer or infectious keratitis, getting more serious,
Definitely.
4, acute anterior uveitis,
Inflammation inside the eye.
and 5, acute primary angle closure glaucoma, a true emergency.
That's a solid list to work through. And the source guides us on how to use the symptoms to differentiate.
It does. Pay really close attention to the pain. What's its character? Is it superficial, gritty, like sand?
Points to the surface. Lids, conjunctiva, cornea.
Generally, yes. Or is it deep, aching, boring, pressing? That suggests something inside the eye is inflamed.
Like the uvea or sclera.
Exactly. Or is the pain felt behind the eye? That makes you think optic nerve, maybe orbital structures, location, severity, vital clues.
What about photophobia? Light sensitivity?
That's a really significant one. The source links it strongly to uveal tract involvement, the iris, the ciliary body. If bright light hurts the eye, think inflammation inside.
Okay. And vision loss, obviously crucial, whether it's present or not.
Immediately helps stratify things. And if the main complaint is itching,
Big allergies.
yeah, the source points towards allergic eye disease. And again, never forget systemic connections. Always ask, always assess.
So you gather the symptom profile, then apply that systematic eye exam we talked about.
Right. Each finding vision, pupils, the look of the conjunctiva, the cornea, the anterior chamber, the fundus, helps you piece together the puzzle and filter through those 5 possibilities.
All right, let's take a closer look at each one. Starting with conjunctivitis.
Okay. Conjunctivitis, pink eye. Usually it's a red eye, some discomfort, maybe discharge watery or sticky.
And the key sign?
Generalized conjunctival congestion. The whole white part looks pretty uniformly red, and critically, as the source emphasizes, vision is usually relatively well preserved.
That's a big point, isn't it? If the vision's okay, it steers you away from the really sight-threatening stuff on that list.
It's a very strong indicator, yeah. Now, there are variations. Adenoviral conjunctivitis, for example, might come with swollen lids, maybe some bumps under the lids, follicles, maybe swelling of the conjunctiva, that's chemosis.
Yeah.
And sometimes you can feel a swollen lymph node in front of the ear. The discharge can vary too.
So for the first responder, what's the main job here?
Rule out the more serious conditions. Careful exam is key. You'd only really send a swab if it looks very unusual or you suspect something atypical.
Management.
Hygiene is huge. These things spread easily. Fomites, hands, separate towels, pillows.
Good advice.
Cold compresses can feel good. Gently wiping away discharge. Medication-wise, usually topical blood spectrum antibiotics and lubricating drops, maybe 3-4 times a day for a week or so.
And it usually clears up fairly quickly.
Typically 5 to 10 days, but there's a potential complication with the viral type mentioned in the source.
So sad.
Something called immune inflammatory keratopathy. It can show up like 10 to 14 days later, little inflammatory spots on the cornea.
And that can affect vision.
Yes, if those spots are central, right in the visual axis. The source mentions topical steroids might be considered for those visually significant ones, but it also notes they can resolve on their own. Eventually. Could take months, even years.
Interesting. Even something common can have a sting in the tail. Okay, next, painful red eye. Foreign body on the ocular surface.
Right. This can be obvious sometimes. You see it right away. Other times, you need magnification. Slit lamp is best, but the source suggests even an ophthalmoscope dialed up to plus lenses or a simple loop can work.
And what if they feel something, but you don't immediately see it?
Gotta look thoroughly. Check under the lids the conjunctival fornices. Definitely flip the upper lid. Sometimes you even need a doubler version to see way up high.
What kind of things are we talking about?
Dust, eyelash, insect wing, bit of plant husk, anything small that flies around.
Removal. If it's just sitting there.
If it's loose in the sac or on the lid margin, irrigation with saline or water might flush it out. The source also mentions fine forceps or a light brush with a cotton bud.
But carefully.
Very carefully. Caveats are important. Don't lose it deeper, don't push it onto the cornea, don't cause more damage.
And if it's stuck on the cornea?
That's different. Needs an ophthalmologist. The source is clear. Removal under topical anesthesia, find instruments using a slit lamp or operating microscope.
So, specialist job.
Definitely. And after removal, same drill. Broad spectrum topical antibiotics and lubricating drops for about a week.
Got it. Surface stuff, maybe. Corneal needs referral.
Ah.
Okay, number 3. Corneal ulcer or infectious keratitis.
Now we're talking serious. This usually happens after some kind of break in the cornea surface, maybe trauma, or a big risk factor is contact lens use.
And the symptoms?
Pain can be quite severe. Vision is usually down, especially if the ulcer is central over the pupil.
What are the signs to look for?
You're looking for an actual defect on the cornea surface, an epithelial defect, plus corneal infiltration. That means the cornea looks cloudy or opaque in that area, lost its shine. And you'll see that redness concentrated around the edge of the cornea's circumcorneal or ciliary congestion.
So not diffuse redness like conjunctivitis, but focused redness plus visible changes in the cornea itself.
Precisely. And the source labels this a serious condition. No ambiguity there.
Immediate action.
Immediate referral to ophthalmology. However, there's a crucial first step for the initial physician emphasized in the text.
Which is?
You must start hourly broad-spectrum antibiotic drops before they see the specialist. Moxifloxacin or gatafloxacin are mentioned.
Hourly. Wow.
Yes. And if they wear contact lenses, you need something that covers Pseudomonas as well, like tobramycin or ciprofloxacin. Start it hourly, then refer.
That really underscores the urgency. Time is cornea.
Absolutely. Every hour counts in preventing scarring and vision loss.
Okay, 2 painful red eyes left.
Yeah.
Next up, acute anterior uveitis.
Okay, uveitis. Characteristically, this is a unilateral painful red eye, and vision is usually decreased.
What's the pain like?
Often described as deep, aching. It can radiate to the eyebrow, forehead, temple, and it often gets worse with eye movement or trying to focus.
And photophobia is a big clue again.
A distinct clue, the source points out. Very prominent symptom because the iris and ciliary body inside are inflamed. The redness isn't usually blazing, and it's mainly that circumcorneal pattern around the limbus.
What do you see on examination? Signs inside the eye.
Yes. Beyond the reduced vision and the ciliary flesh, you look inside. The pupil is often small meiosed. You might see Kp's keratic precipitates little dots of inflammatory cells on the back of the cornea.
Okay.
And in the anterior chamber fluid, you might see flare and cells. Flare is like looking through hazy fluid. Cells are like tiny dust specks floating. In severe cases, a hypopyon, a layer of pus.
The source also mentioned consensual photophobia.
Yeah, that's a fascinating sign. Shine light in the good eye and the bad eye hurts.
Why?
Because light in the good eye makes both pupils constrict. If the iris in the affected eye is inflamed, that constriction is painful.
Clever. What about eye pressure, IOP, and uveitis?
Usually it's lowered. The inflamed ciliary body often makes less aqueous fluid, but...
There's always a but.
Right, sometimes the pressure can be raised, a secondary rise. Maybe the fluid is thick with inflammatory stuff, or the iris gets stuck to the lens that's posterior synechiae, or a membrane blocks the pupil. All can trap fluid.
Sounds complicated. How do you figure out the cause of the uveitis?
Well, sometimes the history helps, but the source says about half the cases are idiopathic, no clear cause found initially. Longer term, investigation for underlying systemic stuff is needed.
Like what?
Lots of possibilities listed. Infections like herpes, TB, syphilis, toxo. Autoimmune things are common, especially those seronegative spondyloarthropathies.
Like ankylosing spondylitis, reactive arthritis?
Exactly. Psoriatic arthritis, IBD2. Also
Cool.
Behçet's RA, lupus, sarcoidosis, scleroderma. It's a long list. About 50% have an underlying disease.
Why is early treatment so important?
To prevent permanent snarring and complications, especially the iris sticking down to the lens, leading to a messed up pupil and vision loss.
Main treatments.
Topical steroids are key for the inflammation. Cycloplegic drops are crucial too. And managing IOP if it's high.
Cycloplegics, the drops that dilate the pupil and relax focusing. Why use them here?
Multiple reasons, the source explains. They relax the ciliary muscle spasm, which really helps with the pain. They dilate the pupil, stopping it from getting stuck down to the lens, or even breaking early adhesions, those posterior synechia.
Examples.
Home atropine is often preferred, lasts a few days. Atropine for severe cases. Tropicamide for milder ones.
Now, you mentioned a huge warning about these earlier.
Yes. Absolutely critical. The source explicitly warns, make sure you haven't misdiagnosed this. Ensure it's not acute angle closure glaucoma before you give cycloplegics.
Because dilating the pupil is the exact wrong thing to do in angle closure, it can make it much worse or even trigger it.
Precisely. You have to be confident in your diagnosis before reaching for that cycloplegic.
And the other big warning was about topical steroids.
Yes. They should only be used in consultation with an ophthalmologist. Giving steroids for the wrong thing, like an undiagnosed herpes infection on the cornea, can be catastrophic. It can worsen the infection dramatically, lead to severe scarring, vision loss, even loss of the eye.
So for uveitis,
Yeah.
maybe start cycloplegics if you're sure it's not angle closure, but steroids and overall management definitely need ophthalmology input.
That's the message. Patients must be referred.
Okay, last one in the painful red eye category. Acute angle closure glaucoma.
This one really stands out. The source emphasizes its distinct set of symptoms and signs. It's different.
What are the hallmark symptoms? Need at least two.
Right. Look for 1. Acute onset eye pain, often severe, and critically, often with nausea or vomiting. That systemic upset is a huge red flag.
Okay.
2. Intermittent blurred vision or seeing halos around lights that's usually from corneal swelling due to the pressure.
Like looking through steamed glass.
Sort of, yeah.
Yeah.
3. Photophobia, like uveitis. And 4. Significant visual loss.
And the signs on exam. Need 3 of these.
Yes. 1. Ciliary congestion, that redness around the cornea again. 2. Corneal edema. The cornea looks hazy, cloudy.
Right.
3, and this is a major differentiator, a pupil that is fixed and mid-dilated, often vertically oval, not small like in uveitis, mid-dilated and non-reactive.
Big difference.
Huge. 4, a shallow anterior chamber. You can see this with that oblique flashlight test light from the side casts a shadow on the opposite iris because it's bowed forward.
Okay.
And 5, the defining feature, elevated intraocular pressure. Often very high, the source says over 40 mmHg frequently.
Wow. That combination, severe pain, nausea, halos, Fixed mid-dilated pupil, shallow chamber, high pressure. Sounds pretty unmistakable once you know what to look for.
It's a classic presentation of the drainage angle inside the eye getting suddenly blocked.
Yeah.
Mechanical problem.
Who's most at risk?
Elderly individuals, especially women, people who are farsighted, hyperopic, tend to have anatomically smaller eyes, shallower chambers, things that dilate the pupil. Prolonged reading in dim light, stress, and certain medications are a big one.
Which ones?
Anything anticholinergic, antimuscarinic, some antidepressants, antipsychotics, antihistamines, sympathomimetics, basically anything that can cause pupillary dilation, mydriasis.
So if you suspect this acute angle closure glaucoma, what's the emergency plan?
Priority 1, get that pressure down fast. Reassess IOP every 15 minutes early on, the source advises. You need to hit it from multiple angles.
How?
Decrease aqueous production, topical beta blocker like temolol for contraindications like asthma, COPD, heart issues, systemic agents like acetazolamide 500 milligrams orally, maybe IV mannitol for osmotic effect.
Okay, reduce fluid production. What else?
Try to open the angle physically. Use topical cholinergic drops like pilocarpine. Frequent doses 1-2 drops every 15 minutes for maybe 4 doses. This constricts the pupil meiosis, pulling the iris away from the drainage meshwork, hopefully letting fluid out.
And then?
Immediate ophthalmological consultation. No delay. They need gonioscopy to directly visualize the angle and definitive treatment.
Which is?
Usually a YE laser iridotomy, the source says. A laser creates a tiny hole in the iris, bypassing the blockage. This is done once the pressure is controlled. And they'll likely do the other eye prophylactically, too, as it's probably at risk.
So slam the pressure down medically, then get the laser procedure done urgently.
That's the essence of it, yeah.
Okay, let's switch gears to loss of vision. The source starts with a really stark statement here.
It does. Any acute loss of vision is an ophthalmic emergency. Full stop.
Can't get clearer than that. Divided into painless and painful loss. Let's start with painless loss of vision. What are the big causes listed?
It's a critical list. Retinal vascular occlusions, artery or vein. Arteritic ischemic optic neuropathy.
Like from temporal arteritis. The eye itself might not hurt much there.
Right. The headache is the pain, usually. Also, non-arteritic anterior ischemic optic neuropathy, NAION, retinal detachment, vitreous hemorrhage, certain macular problems, neuro-ophthalmologic causes. And interestingly, even things like hysteria or toxicity from methanol or even Viagra are mentioned.
That's a wide range. Any clues from the timing?
Yes, the source notes that the vision loss is very sudden, like over seconds, think vascular, ischemia in the retina or optic nerve.
And a specific point about floaters versus detachment.
Yeah, a posterior vitreous detachment, or PVD, is common, causes floaters, but you can usually see through them. A retinal detachment is much more serious, causes a definite field defect, like a curtain or shadow. Big difference in urgency.
The source then dives into specific emergency vascular syndromes. First, temporal arteritis, or giant cell arteritis GCA.
Right. This is that autoimmune vasculitis we mentioned affecting arteries like the temporal and ophthalmic. It causes arteritic acute ischemic optic neuropathy, AAA, starving the optic nerve of blood.
Who gets GCA?
Classic patient is over 50 years old. Key features: headache, maybe a tender or pulseless temporal artery, high ESR, often 50, and ultimately a positive temporal artery biopsy confirms it.
But there are other symptoms to watch for, too.
Oh, yes. Jaw pain with chewing claudication, double vision, temple pain, maybe a gradual peripheral vision loss, low-grade fever, and those general constitutional symptoms: feeling unwell, tired, muscle aches, night sweats, weight loss, sometimes for weeks or months before the vision is hit, less common. Ataxia, hearing loss,
Signs on exam.
often profound vision loss, a definite RAPD. The optic disc might look pale and swollen. You might feel that tender, prominent temporal artery or scalp tenderness. Maybe balance or hearing issues.
Key tests.
ESR and CRP, both are important. The source notes that if both are normal, GCA is very unlikely, high negative predictive value. But a normal ESR alone doesn't rule it out. You need both.
This sounds incredibly urgent. Therapy?
Steroids, immediately. No hesitation. If there are no eye symptoms yet, oral steroids. If any eye symptoms, vision loss, diplopia, IV, steroids, and the source is emphatic. Do not delay treatment waiting for the biopsy. Start the steroids now.
What difference does starting immediately make?
Huge. The source cites data. 60% improve vision significantly if treated within 24 hours of eye symptoms starting. Only 5% improve if treatment is delayed past 24 hours.
Wow, that's incredibly stark. Powerful reason to act fast. Okay, next vascular emergency. Central retinal artery occlusion, CRA.
This is the stroke in the eye. Sudden, abrupt, usually painless vision loss can be total loss, down to light perception only. Unless there's a spare artery feeding the very center, the fovea ciliar retinal artery, then central vision might be preserved.
What does the back of the eye look like?
You'll usually find an ROPD. The retina looks pale, ischemic, blanched where the artery is blocked, and the classic sign, the cherry red spot at the macula.
Why red?
The macula fovea is thin, its underlying blood supply, choro, shows through, appearing red against the pale, swollen, ischemic surrounding retina. The optic disc looks pale too eventually, and the arteries look thin.
Management goal for CRAO.
Restore blood flow. It's extremely time sensitive. The retina doesn't tolerate lack of oxygen for long.
What can be tried?
Several things listed. Vigorous eyeball massage, trying to dislodge the clot. Antiplatelet therapy like aspirin. Lowering the eye pressure timolol drops. Acetazolamide, mannitol. The idea being lower pressure might improve perfusion.
Any others?
Breathing into a paper bag briefly is mentioned, increasing CO2 to try and vasodilate retinal vessels. Thrombolytics are a possibility, but complex, usually specialist decision. It's about doing everything possible quickly.
Okay. Third vascular one. Central retinal vein occlusion, CRVO. Blockage of the main vein.
Right. Also, typically sudden, painless vision loss, sometimes noticed upon waking. RAPD might be there, might not. Depends how ischemic the retina is.
Fundus appearance. Very different from CRA.
Oh, completely different. It's a bloodbath, visually speaking. Marked swelling of the disc and retina, veins are hugely engorged and twisted, and tons of retinal hemorrhages everywhere. Dots, blots, sometimes flame shapes. It's often called a blood and thunder fundus, though the source just describes the extensive hemorrhages and engorged veins.
Action for CRVO.
Refer to ophthalmology. They need to check for risk factors, hypertension, glaucoma are common, and manage potential complications like abnormal blood vessel growth.
Okay, that covers the main painless vision loss emergencies.
Sure.
Now, painful loss of vision. The key condition here is optic neuritis.
Right. Inflammation of the optic nerve,
Yeah.
usually linked to demyelination, especially multiple sclerosis in adults.
Typical patient.
Women aged 15 to 45 is the most common demographic mention.
Classic presentation.
Often a triad. 1, unilateral vision loss. 2, pain, specifically pain with eye movement, moving the eye hurts. 3, dyschromatopsia colors look washed out, faded, especially reds, like looking through frosted glass.
Exam findings.
Vision's usually way down. Fundus exam. Often it's normal.
Normal.
Yes, the famous phrase is, patient sees nothing, you see nothing, because the inflammation is often behind the eyeball retrobulbar. Sometimes, if the nerve head itself is swollen, you might see blurred disc margins.
But the key sign is?
The RAPD, very common, crucial sign of optic nerve dysfunction. That paradoxical dilation when you swing the light to the affected eye.
And the bigger picture is significant.
Its strong association with MS. The source notes that finding plaques on an MRI significantly increases the risk of developing MS later.
Treatment, based on that big trial.
Yes, the optic neuritis treatment trial findings are referenced. Standard is IV methylprednisolone high dose, 250 milligram, 4 times daily for 3 days, followed by an oral prednisone taper for a week.
And the benefit.
Speeds up visual recovery, though doesn't change the final outcome long term. Importantly, it was shown to delay the onset of definite MS by about 2 years.
So high-dose EV steroids. Got it. Okay, pulling this all together, the source gives a really concise list of emergencies needing prompt ophthalmology consultation.
Yes, this is a great summary for the front lines. Immediate specialist review needed for.
Acute angle closure glaucoma.
Definitely.
2, severe uveitis.
Okay.
3, acute loss of vision, specifically mentioning CRAO, temporal arteritis, retinal detachment, and optic neuritis.
All the big ones we discussed.
And 4, significant corneal ulceration, defined as bigger than 1 millimeter.
That's a really practical takeaway list. The source also had that table of common emergencies and key steps, including some traumatic ones for context.
Right, it reinforces the main actions. Ischemic optic neuropathy, rule out GCA, CRAO, rule out GCA and emboli sources, macula on retinal detachment, immediate referral, acute third nerve palsy, rule out aneurysm, urgent, microbial keratitis ulcer, culture, start antibiotics, follow closely, open globe injury, emergency repair, angle closure glaucoma, control IOP, endophthalmitis, infection inside eye, antibiotics refer, alkali burn, copious irrigation urgently, orbital cellulitis, systemic antibiotic.
That list really drives home the core message, doesn't it? These conditions are immediate threats. Delay equals potential permanent loss.
Absolutely. Recognition, appropriate initial steps, and urgent referral are paramount. That's the pathway to potentially saving sight.
So we've taken a really deep dive into these critical non-traumatic eye emergencies. Broken down symptoms, signs, how to tell things apart like uveitis and angle closure, the urgency of GCA and CRAO, and those vital first actions.
Understanding the type of pain, the pupil state, vision status, associated symptoms like nausea, systemic links. These are the crucial clues the source provides to navigate that differential diagnosis.
It really feels like the source is saying this basic knowledge isn't optional for first contact clinicians. It's absolutely essential.
It truly is. Having that high index of suspicion is key.
What really stands out to you after going through all this detail?
For me, it's how easily serious things can be missed or misdiagnosed if you're not careful, like confusing uveitis and angle closure, similar pain maybe, but totally different pupil, totally different initial treatment, and getting it wrong is dangerous. Or using steroids inappropriately, it just highlights the need for meticulous assessment. The potential for harm from a wrong step based on incomplete assessment is quite sobering.
That's a great point about the potential pitfalls. Here's a final thought for you, drawing from the material. We've seen how many of these eye emergencies, GCA, CRAO, even uveitis, sometimes have systemic roots or implications. How does recognizing an acute ophthalmic emergency force you to think beyond just the eye, prompting a broader assessment of the patient's overall health, potentially uncovering other serious, even life-threatening conditions that manifested first in the eye? It really reinforces that concept of the eye as a unique window, doesn't it?